All right, so here we go with cardiac disorders, cardiac pathophysiology. Part of it we're going to have to do is review normal cardiac physiology so that it kind of makes sense as we go through this system. The heart is the pivot of every organ system. And if the pump fails, you will start to notice downstream effects. And sometimes the problem is because the pump is failing, and sometimes something else is failing and it's affecting the pump. And so your job is going to be to figure out which failed first. Where do I go for that underlying cause? So this is why cardiac pathophysiology is the anchor of just about everything you do. You need to master this content. This is going to be very deep, need to know stuff just for everyday function. As often as you check a blood pressure, you are using all of these factors in terms of the cardiac system. So here you're going to be a detective. You're going to figure out chest pain, fainting, irregular heartbeat, and your job is to figure out what is the underlying story and what does it mean. Okay, so why do we emphasize this? So here's what I want you to know. I'm not looking for you to memorize guidelines. The guidelines change every 5 years. In fact, I think since we last met, new hypertension guidelines came out. And now we're all hypertensive. Because if you have 130 over 80, which is the new hypertension, by the way, 140 over 90 just went out the window, the incidence of hypertension went from 32% to 46% in the nation. Why? Because they just changed the definition as to what qualifies. We used to call that stage one, lifestyle, etc. Now, hypertensive consider meds. So you can see why memorizing guidelines is not useful, but it's more useful if you can learn mechanisms. So if you understand the concepts of preload, afterload, oxygen demand, and then you can adapt to any drug or algorithm or pathology that you may encounter. And the other thing I need you to pay attention to here are these red flags. So these red flags are not meant to be checkboxes. These are pathophysiologic alarms. So if a patient comes to you with diaphoresis or chest pain or the symptoms, or you realize that the sympathetic system is in overdrive and they're having a catecholamine storm or they're hypoxic as the reason why the heart rate is up, the blood pressure is up for now before it's down. These are the red flag mechanisms that you need to pay attention to. Now, I'm going to give you some clinical decision tools or calculators, and you may have seen these in use. For our purposes here, you don't need to know, you don't have to memorize them by any stretch. These are all free devices in your phone. You can calculate what does CHASVAT mean and TIMI and all these scores. Those are just ways to help you systematically organize the information so that you don't forget to consider all of the various factors that may raise the level of acuity or help you realize, okay, conservative medical management's okay. And that's really the question. When do you aggressively intervene and go to the cath lab versus when do you do medical management? And a lot of times, so if you prematurely go to the cath lab, while you can visualize the vessel, that whole process is not without risk. So I tell you what I tell the psych NPs, the patient should not be worse off having met you. You need to be sure you're offering the right amount of care given the circumstances. And if they're stable and can recover on their own, then we don't have to expose them to the healthcare system if we don't need to. So the other thing is you need to get good at pattern recognition. And so those scores sometimes will help you recognize the patterns. Remember, you're always treating the patient, not the score. All right. Not the, oh, it's this, so I have to go out. No, no, no. Make sure the patient is who you're actually treating. The test is to confirm an index of suspicion, not to go cast a fishing line for whatever comes up. So here we go. Let's talk about these mechanisms. So why you interpret labs and imaging differently is going to be because of what you have decided the underlying cause is. What's the driving factor here? Is this chest pain an issue of wall stress, ischemia, inflammation? And the other thing we need to consider, because this is a pathophysiology course across the lifespan, so I need to cover some pediatrics, pregnancy, and geriatrics here, because I know a lot of you are adult geri NPs, but the psych students are family psych, so their pathophysiology has to be family across the lifespan, even though they're not going to contend with these issues, but we have to cover the lifespan. So this looks different. So a murmur, say in pediatrics, could be nothing, or it could be a cyanotic heart defect or congenital defect. In pregnancy, It might be normal to be short of breath, but it could also be an issue of like peripartum cardiomyopathy. And so you got to figure that out. An elderly person who's confused, you will say, oh, delirium, but you need to figure out, is that delirium due to hypoperfusion of the brain? And so that's kind of what you're trying to figure out. What does this clinical picture mean in the context given the developmental stage you're dealing with? So it's the red flags that will determine for you if the mechanism is stable or unstable, and that will determine the care you eventually provide. So take a look here. These four levers, these are the things that you will manipulate in order to treat the patient. And I told you this on the first day of class, but this bears repeating and remembering. There are four factors that affect your blood pressure and your overall hemodynamic status. And when we say blood pressure, what we're really talking about is your ability to perfuse vital organs, which includes the brain, the heart, the liver, the kidneys, right? Those vital organs need to be perfused. And it's all about preload, afterload, vascular resistance, and heart rate contractility. All right. So those are the four things that your medications or fluids or interventions are looking to manipulate in order to affect the desired outcome: preload, afterload, contractility, and heart rate. So, what do you mean by preload? Well, preload is the volume that returns to the ventricles. And if you don't understand and borderline memorize blood flow through the heart, I suggest you make every effort to memorize the blood flow through the heart, naming every vessel and valve that the blood has to pass through from the superior inferior vena cava all the way until you get to the aortic arch. You should name all those structures along the way because all of that is what's going to play out when you do a physical exam. And that will really help solidify what you're assessing in the patient. Suffice it to say, preload, what is that? Preload is the volume returning to the ventricle, and it tells you about the stretch on the myocardial fiber before contraction. So how much fluid is coming in? So when you think preload, you're thinking things like JVD, edema, pulmonary edema, okay? That means too much preload, too much volume in the system. Those are the people that you want to maybe reduce preload with, say, diuretics or something. And what you're contending with is congestion usually means too little forward flow, meaning flow out of the heart or back up. Okay, so there's too much preload. Now, it can go the other way where you have hypovolemic collapse where you don't have enough preload. That's the other problem that can happen. So, with each of these factors, you can have too much or too little. Too much preload, pulmonary edema, dependent edema, RAAS, CHF. Too little preload, poor cardiac output, not enough to perfuse the vital organs. So that's the preload issue. Afterload is the resistance that the left ventricle has to pump against to get blood into general circulation to perfuse the brain, right? High afterload is what you see in things like aortic stenosis, hypertension. And then low afterload is something that you would probably see in septic shock. So that's why in septic shock, there's this big push to quickly fluid volume resuscitate because there's not enough fluid to fill those vessels. The reason we need that fluid is if the pressure is too low when they're in shock, we don't have enough forward flow to perfuse the vital organ. So that's why we're trying to pump in fluid in somebody with a low afterload to fill that space. And likewise, if the vascular resistance is too high, that's the person we're trying to dilate the vessel so that the heart doesn't have to pump as hard to get through that aortic valve to the aortic arch to the rest of the body. So systemic vascular resistance is the other component. That's the resistance to blood flow offered by all systemic vessels, excluding pulmonary circulation. And there's a number, it's 800 to 1200 dynes. If you work in CCU or CTICU, these numbers are your friends. And in the old days, before the computer would spit out the number, you would walk around typing in heart rate, stroke volume, cardiac output, and vascular resistance into your little computer. You open a little book and you try to write these numbers on a flow sheet, and you look like you're going to sail a ship across the ocean with this big navigational thing. Now the computer spits out the number, and your job is to know, is that right or not? Because different things can affect it. Is the thermometer probe too hot or too cold? You take it, you dip it in the ice water, and then shoot that cardiac output again. Oh, it's working now. Shoot 3. We'll take the best one out of 3. That's a made-up thing. We just average the 3 cardiac outputs, and the poor patient's getting bolus with fluid the whole time, and it makes us feel better because the problem is if that cardiac index goes down, you're going to have a lot of work to do all of a sudden. So you're really hoping we don't have to do that. Suffice it to say, afterload is the amount of oomph that the ventricle needs to pump against. And since we mentioned pumping, there is another thing. Oh, 2 other things that affect the afterload. Viscosity, how thick is the blood? Right? And also, how long is the vessel? How far does it need to get? Because you realize you got to get to the end point. We have to perfuse all the way to the fingertips. And so that also affects afterload. The other thing is the pump. How efficient is this heart squeezing, right? So we call that contractility. That's the intrinsic strength of the pump. And so if it's an injured myocardium, like what? Like you had a heart attack, right? That heart is not able to pump well to meet the cardiac demands, the biological demands. So we give things like inotropes to enhance the pumping, right? That's the dopamine and the dobutamine. We want a more squeeze. And that's okay for the short term, but if you keep making a more squeeze, you're going to keep raising the heart rate and increasing the demand. So that's kind of a double-edged sword. Life becomes trade-offs. But you got to do what you got to do in the short term. So a failing ventricle under chronic catecholamine bombardment, what does that mean? Stress response, adrenals are firing, right? That's surging the heart rate, anxiety, raising the heart rate. The heart can only do that, but for so long. And of course, what that does also is it raises the heart rate. So raising the heart rate will definitely affect your blood pressure. It can definitely shoot it up, right? When I say boo and your heart rate goes up and it matches your blood pressure, great. Now that can only happen for so long. What happens if you go a long time in SVT? Eventually, you reduce diastolic filling so much, there's not enough cardiac output. So sometimes you slow the heart rate down and then the blood pressure comes up, right? Because you're unstable if the pressure is down and you're tachycardic. How many of you take an ACLS? What's the difference between stable VTAC and unstable VTAC? If the blood pressure is perfusing, that will tell you if you have time to sync and cardiovert, or do you have to, God love you, zap, okay, we're done, right? That's your option. So that's the determining factor. What is the blood pressure? How well are you perfusing? So that is the final knob that you can pull on to adjust hemodynamics. If it's too fast, diastolic filling shortens and the cardiac output drops. If it's too slow, then you don't have enough beats per minute to maintain perfusion, and then the heart rate needs to be adjusted to compensate for that. Another factor you need to think about is this issue of stroke volume. Now, you see the formula here. You don't need to memorize it per se, but you need to know what are the factors that involve here. Because normally when we look at MAP, it spits it out on the automatic machine. That's not going to kill me. It spits it out on the automatic machine, and then you, okay, good, 130/80. But the MAP is really what we're caring about here. In the MAP, you see the formula there. It's systolic minus diastolic times a third, and then you add the diastolic pressure back in to get the mean arterial pressure. That is essentially a better measure of perfusion. And so that's what really tells you. And we're looking normally for 60 to 80 milliliters of stroke volume, by the way. That's in the average adult, assuming 4 to 6 liters of blood volume. Again, it's not the number that matters so much, it's the end point. And so the reason I also say that is a lot of this derangement doesn't happen okay, sometimes it happens over, right? Sometimes you can have the massive heart attack and does. But in general, this happens over time. So when something happens over time, your body learns to compensate. And so maybe you're okay with a little bit lower pressure. Or the more alternative is you've walked around with this 200/150 blood pressure for years and you feel fine and your body's gotten used to it. Well, we'll talk about that in hypertension. But suffice it to say, the body adapts. It gets used to its circumstances. So don't get so fixated on the numbers and what they ought to mean. Okay. So now that we know the four knobs, preload, afterload, contractility, and heart rate, how do these all work out in practice? So if you take heart failure decompensation, which problem or which knob is causing you issues here? If we have decompensated heart failure, right? So you have three knobs that are a problem here. You might have too much preload from fluid retention. You might have too much afterload from climbing from that chronic vasoconstriction. And then you also have contractility weakness because this has gone on for some time and the heart can only do but so much. That's the toxic triad, by the way. Too much preload, too much afterload, and the heart is just tired. So that is the toxic triad. And what you're going to see are what? Swollen legs, orthopnea, crackles, and low ejection fraction. Has anyone ever heard of the term bendopnea? I was reading a patho book for fun the other day because I was trying to figure out a book for this class. Bendopnea is when you bend over to tie your shoes and you get very short of breath. Well, that's also a problem because what happens is you have impinged the venous return. So that's also a tell. You bend over to clip your toenails and you get short of breath. We think that's normal. Turns out it's not normal. So I was worried about myself sometimes. But suffice it to say, bendopnea and orthopnea are just ways to quantify how bad the heart failure is. So what about things like hypertension? So here's the deal. You don't just treat the number. If it's a preload problem like volume overload, you're likely to go for diuretics. If it's an afterload vascular resistance problem, that's when we're talking ACE inhibitors and ARBs and calcium channel blockers. Okay. If it's a sympathetic tone that's overdriving, then you're talking things like tachycardia and contractility. That's the one that you're going to do beta blockers with. So the problem is, how do you wind up on so many meds and still the pressure's not controlled? Well, maybe you just picked the wrong knob. You're not dealing with the right mechanism. Now, with respect to shock, cardiogenic shock, what is being affected there? Contractility, right? The heart's not pumping effectively. The contractility is down. Hypovolemic shock, what's being affected there? Preload, right? Not enough volume. Distributive shock, like in sepsis, what's being affected there? Afterload, not enough volume to pump out and fill that big pipe. Okay, so that's the issue. So in each case, you can kind of predict what the hemodynamic profile will be, and you're going to need to know inotrope versus fluid versus pressor, because then you'll be able to figure it out based on which lever in the pumping system is not working. So you don't want to think of these, you want to think of these medications not by name, but more by mechanism of action. What will this drug do to the body? And thankfully, in the rest of medicine, we can do class effects. In psychiatry, they don't do class effects. So like, oh, this SSRI didn't work. Okay, let's try another SSRI. We don't do that in the real world of medicine. In the real world of medicine, we say beta blocker, we say ACE inhibitor, we say calcium channel blocker, whichever one is covered on the formulary, that's the one I'm going to pick because I know I want this mechanism of action. So that's how you pick. You want to memorize drugs based on mechanism of action. So inotropes will increase contractility. So will vasopressors, right? They will increase afterload. And then the chronotropes are things that adjust the heart rate. Normally, we're trying to raise the heart rate with chronotropes. We don't classify a beta blocker as a chronotrope, even though we are bringing the rate down. Okay. So if you had to bring down hemodynamics to three equations to carry around in the back of your mind that you can say, oh, yeah, I remember that from who knows when, it's going to be cardiac output, mean arterial pressure, and oxygen delivery. So first, cardiac output. This is heart rate times stroke volume. Heart rate times stroke volume, but the stroke volume itself is a function of three other knobs, those three knobs being preload, afterload, and contractility. Stroke volume means how much blood is being pumped out of the left ventricle. That's what we mean by stroke volume. Well, what do you think will affect how much is coming out of the left ventricle? How much fluid is there to begin with, how much pressure it needs to pump against, and how good that heart is going to squeeze. So that gives you an understanding of what stroke volume means. So heart rate times stroke volume tells you the cardiac output. So if you see one of those affected, like the tachycardia is too fast, then you'll see maybe low cardiac output, even though it's a high tachycardia, low volume, low cardiac output. Increased vascular resistance, low cardiac output. So tachycardia in hypovolemia is a compensatory mechanism. The body is trying to multiply by doing small stroke volume through faster rate in order to keep that brain perfused. So when you see tachycardia, you should start to think, why are you going fast? Just remember, whatever's happening in the body, it's trying to survive. Don't knock out the survival mechanism. I don't like tachycardia. I'm going to beta block and bring that right down. Wait, stop. You need to figure out, why are they tachycardic? If they're tachycardic because they're hypovolemic, the answer is not beta block and knock out the compensatory mechanism. The answer is give volume. This happens a lot in primary care. You'll find little old lady who's dehydrated and not eating well and tachycardic and has a comorbid hypertension, and she continues to take her beta blocker because her doctor said keep taking your medicine, and she gets up from the chair, she's orthostatic, she doesn't have the heart rate to jack up and compensate because she's governed by the beta blocker, and boom, down she falls and breaks a hip. So it's really important that you figure out, why is the heart rate fast? Is it compensatory or is it a primary driver? Okay. The second is mean arterial pressure. This is what keeps your organs perfused. That's cardiac output times systemic vascular resistance plus the CVP. So in other words, it's flow multiplied by the resistance plus a little contribution from central venous pressure. And this explains why distributive shock, low SVR, brings that map down. The pipe is too open and it needs to be filled. Even though in distributive shock, you may have a high cardiac output because why? The resistance is so low, full of volume, and you'll think you're doing great. Initially, it is high, but eventually it's going to fail. And then finally, this delivery of oxygen, because at the end of the day, what we're talking about is, are you getting enough oxygen to and removing enough gunk, CO2, et cetera, lactic acid from? And that's really what we want to talk about here. So delivery of oxygen. So cardiac output times how much oxygen is carried in hemoglobin is essentially what we're trying to determine by what is being demanded. So in someone like septic patient may have a normal cardiac output, even though the hemoglobin is 6, they're having poor perfusion because the thing does not have enough capacity to carry enough oxygen to them. Now, no heart failure talk would ever be complete unless we mention Frank Starling. Now, you all remember Frank Starling probably from your undergraduate days, but this is that rubber band theory. The more you stretch, the stronger the snapback. The more you stretch, the stronger the snapback. Until, of course, I can't do anymore, right? So what happens is the elastic in the underwear has fallen to the ground because it can only stretch but so much for so long, and it just gives up, and you get this wobbly heart that's inefficient at pumping out. So that's kind of what Frank Starling is talking about. Too much preload, the fibers overstretch, they become less efficient over time, and this is why the volume load can help initially in hypovolemia, but if they're in congestive heart failure and they don't have the ability to pump forward, that increased volume you're giving them to get the blood pressure up may drown them, because it doesn't have enough oomph to get the blood through circulation. So never talk about cardiac function or blood pressure to anybody unless you are willing to go out and say, but do you mean preload, afterload, heart rate, or contractility? This is going to be the quintessential question. When I worked general surgery overnight and the nurse would call and tell me the pressure is down. Or my favorite, hi, so-and-so has a heart rate of 110. You will get these phone calls. What is my next question? So-and-so has a blood pressure of 110. What do I want to know? What is the blood pressure? And without fail, hold on. What do you mean, hold on? It's 2 o'clock in the morning. You call me with an abnormal heart rate and didn't have a blood pressure to go with it. I need you to connect the dots. If you're going to tell someone something about the heart rate, you need to say something about the blood pressure because they're related. Because if you tell me 110, right, and the blood pressure is 160/90, that's a different tachycardia, right? And I could beta block that rather than you tell me the heart rate's 110, 120, but the pressure is 80/60. Okay? They're both treated differently. She just says abnormal number. Let me make a call now. We're stuck. No, I need the blood pressure. And I also would like to know the pulse ox at that point because I want to know if we're perfusing. So that's why you need to realize how these numbers relate, because they're going to call with random numbers. And you're going to say, now do something. I'm not the NP. I don't know. I also don't think you're the nurse. Put the cleaning lady on the phone. She'll know to look at the heart rate and blood pressure. In fact, she does. So the cleaning lady that I used to have in the medical ICU, she'd done it so long that she realized when urine output was trailing off, and she would come and whisper to the nurse, the urine is not right. How do you know? Because at 6 o'clock in the morning, there's supposed to be a line in the bag. There's no line in his bag. He's not making enough urine. What did she know? She knew about the natriuretic effect overnight because I know you're going to give the Lasix. They all give the Lasix here. I mean, it was hysterical, but she was right. And you'd walk in the room, you jiggle the tube and see if something's caught. And that woman has done this long enough. What is she doing? Pattern recognition. Pattern recognition. You cannot check out. You got to keep those patterns alive. Okay, so suffice it to say, whenever you talk about blood pressure, preload, afterload, vascular resistance, heart rate, no matter what you're talking about. Okay, here we go. Okay, so what is the most common cardiovascular disorder you think you're going to face in primary care? Hypertension. Everyone has it now. 46% of the population now has hypertension because the last council just voted. So the mistake is that you wind up thinking you're treating a number rather than a patient. And so what that means is this. Some of the most basic things, the right cuff, they're calmed down, the legs aren't crossed, they're in proper positioning. We're not just rushing through and screaming and yeah, you sat down, okay, blood pressure, right? So suffice it to say, I'm going to assume that you've checked it and it's proper. Okay, let me just give that here. When you get into primary care 1, you'll spend a little time on making sure that the blood pressure is properly measured because you're about to put them on medicine that could derail the whole situation. So you need to verify. And sometimes they tell you bring them back in 3 weeks, 3 blood pressures in 2 weeks, or you go home with home blood pressure monitoring and check the morning and the night, bring your machine to the office so I can corroborate with my manual, all of the things. So, because you want a good level of agreement. So you want to make sure, assuming that they're truly hypertensive, now what? Well, you don't want to lower the numbers for the sake of just lowering the numbers. Because really, it's not about high blood pressure. It's what does high blood pressure mean, right? We're worried about atherosclerotic cardiovascular disease. So there's a calculator free online, and you can do this. Fortunately, it only works if you're over 40. Anyone under 40 doesn't make the cutoff. But what you're really looking for is signs of end organ dysfunction. What damage is this blood pressure causing? Right? Do you have such bad blood pressure that you have LVH and retinopathy and chronic kidney disease? Well, that means you've had this for some time, right? That tells you this is not just isolated white coat hypertension. This tells you you've had this, you're hypertensive and you don't even know it because what? It's called the silent killer for a reason. There's no symptoms. I feel fine. I feel fine with my 200 over 120 that I've gotten accustomed to. So too much volume. So your question now when you're looking at hypertension is how does the hemodynamic equation help? Blood pressure, remember, is cardiac output times systemic vascular resistance. So too much volume, too much preload, diuretic. Too much constriction, too much SVR, ACE inhibitor, ARB calcium channel blocker. Too much sympathetic drive, beta blocker because the heart rate is up. And when should you suspect though secondary hypertension? Because not all hypertension is essential hypertension. My bias is if you don't fit the profile of what I think a hypertensive person should look like say, you're 22 years old and you come in, oh, you're hypertensive. That's unusual. That's the thing that should trigger a secondary hypertension investigation because, you look like a runner. You tell me you're eating well. You look the epitome of health, but your blood pressure is enough to make my eyebrows hit, well, when I had a hairline. But that's not good. 180 over 110 in a 22-year-old? That doesn't make sense to me. So that's when you need to start looking for underlying clues. And so in someone like that, it's typically going to be some sort of genetic situation or a secondary finding. So you're going to need to go looking for secondary causes of hypertension. And you may still put them on medication while you're doing the workup, but you're going to need to figure out why are you like this? The most common issue is going to be the RAAS system, the renin-angiotensin-aldosterone system. That's the most common issue. And usually there's some early kidney disease, and you have to contend with that first. But suffice it to say, you need to proceed in a systematic fashion considering what are all the different causative factors. So let's go to the next slide. So what is the difference now between hypertensive urgency and emergency? Urgency is just the scary number, okay? 180 over 120, urgency, without target organ damage. Well, how are you going to know? if there's target organ damage. Well, the patient looks okay, but they may have a little headache, but there's no stroke, there's no MI, there's no papilledema. This person, you're going to bring them down gradually over 24 to 48 hours. But urgency is the scary number, 180 over 120, but they have signs of end organ damage, altered mental status, chest pain, acute kidney injury, the creatinine's bumped, retinal hemorrhages. There's signs of end organ damage. You take the ophthalmos, go, oh, look at that AV nicking. Oh, and you're dizzy and confused. Let's scan your head. Let's pee in the cup. Let's check the urine. Let's check for hematuria. Let's check for protein in the urine. Draw the chemistry. That's signs of end organ damage. Let's do an echo. Let's do a renal ultrasound. That's how you're looking for end organ damage. So here, the pressure itself is injuring the organs, but you have to be careful. You need to treat this person slowly, because if you immediately drop that blood pressure to normal, you're going to trigger these autoregulatory mechanisms. You realize they've gotten used to this number, so you have to gradually resensitize them. The brain and kidney is used to this higher perfusion pressure, so if you cut it off, they're going to have a problem. So if you drop a MAP by, say, 50% in an hour, you can develop like major infarct and major acute kidney injury. So we aim for about 25% reduction in the first hour, 25 in the first hour with end organ damage symptoms, and then gradually thereafter. Don't fix this problem overnight. They didn't develop end organ damage overnight. In special populations like pregnancy, the thresholds are lower. You treat 140 over 90. They use ACE inhibitors, and ARBs are out. No ACE, no ARB in pregnant people. Okay, teratogenic. They like beta blockers. They like catecholamine blunters, labetalol, methyl-dopa, Aldamet. Remember Aldamet? 100 years ago, they used to have a drug called Aldamet, methyl-dopa. And then nifedipine. Those are the safer options. They will vasodilate. They will bring the heart rate down. In the elderly, you may tolerate a higher pressure. Don't be supratherapeutic in the elderly, because they may stand up and go down. So I'm okay with a pressure of 150 in someone over 65 to 70, assuming all other things are controlled. So be careful with that, because overtreatment can lead to falls. How do you define resistant hypertension? Well, if the pressure remains 140 greater than 90, although now I think that might come down to 130 over 80, I'm not sure. But suffice it to say, if they're on 3 or more medications, one of which is a diuretic, we call that resistant. The other thing to make sure it's not pseudo-resistant. So just because you prescribe the medicine, it doesn't mean they're actually taking the medicine. You will discover that half the prescriptions may go unfilled of all the meds, not just the blood pressure meds. That's not uncommon, actually, for various reasons. It could be social media. It could be someone told them something bad about the drug. Yes? Yeah. What? Oh, money. That's cynical, but possible. Yeah, so yes, more people obviously are going to be treated. We would say that they probably found earlier incidents of end organ damage over time. The theory is that if you were to treat it, everyone's worried about cognitive impairment. Well, what do you think the driving cause of cognitive impairment is? It's untreated hypertension. And the problem is most people aren't getting checked. And so that's the leading cause of cognitive impairment. It's vascular dementia, multi-infarct dementias. Anyway, so the primary care red flag would be a 25-year-old with a pressure of, say, 200 over 110, not essential hypertension. That's the one you're going after secondary causes. The other thing to keep in mind is if they have worsening renal function after you put them on an ACE or an ARB, that should be a red flag. That's the person, oh, you did what now? So when you start someone on an ACE or an ARB, you should bring them back in a week or two to recheck the blood pressure and recheck a chemistry. If you notice that the creatinine is suddenly bumped and the pressure is not controlled or even heading in the right direction, that's the one you're going to send for a renal ultrasound. What you got to do, though, is you need to stop the ACE ARB 48 to 72 hours before they have that ultrasound. And then you have it. Now, there is another type of ultrasound that you can do called an ACE-induced renal ultrasound. This is where you give them a very short-acting ACE inhibitor, captopril, about 60 to 90 minutes before. So you do a baseline ultrasound, no ACE inhibitor, and then you give the ACE, and then you check 90 minutes after you give this short-acting ACE. And if they develop renal constriction, send that person off to renal. They may benefit from stenting, and that may be definitive treatment for their hypertension. Now, why would that be the case? Well, I'll tell you. So when you suspect hypertension, the way the diagnosis is made is you're going to follow this official, there's guidelines. So you can follow the guidelines, but suffice it to say 130/80 is what we're calling hypertension now. And the workup is pretty straightforward. Baseline labs, BMP, potassium, sodium, renal function, urine analysis, microalbumin. All of that is to look for signs of end organ damage. And some will say plus or minus an EKG, plus or minus an echo. That will tell you left ventricular hypertrophy, tell you how long it's been standing there, and give you an idea of, have you had a heart attack that we missed, and is there any wall motion abnormalities? So that's the other thing. The other thing I do is if I find hypertension, I give them a referral to ophthalmology. I need you to go see the ophthalmologist because I'm not real good at finding the nicking. They're much better at it than I am. Let's get that dealt with as well. So you make friends with a good ophthalmologist because whether you're diagnosing diabetes, blood pressure, and other esoteric things, it shows up in the eyes a lot sooner, and that's helpful to know. The pharmacology should be stepwise: ACE inhibitors, diuretics, calcium channel blockers. And with the elderly, you start low and go slow. And in the pregnant population, we're looking primarily at beta blocker and calcium channel blockers. Okay, so pay attention to this slide. We're going to be here a while because what you have here are three mechanisms of hypertension. Yes, those four parameters, blood preload, afterload, vascular heart rate, are going to be the problem, but these are the three ways in which they become the problem. And what will happen is, this is a good intro because there's a cardio-renal interplay that we will talk about, and then next week we'll talk about renal. So when the kidney senses a low blood flow state, maybe low blood pressure, maybe low blood volume, maybe renal artery stenosis, the kidney perceives it's not getting enough. What happens then is the cells, the juxtaglomerular cells in the kidney, they release renin. And renin is like the spark that starts this cascade of events. In renovascular hypertension, like when you have renal artery stenosis, the kidneys are forever thinking, we're not getting enough. So it keeps releasing renin so that they get adequately perfused. And that's the hope, right? So what happens is you'll find high blood pressure. The pressure's up to enhance perfusion. Well, renin then acts on the liver-produced protein called angiotensinogen, and this thing breaks down into angiotensin 1. But this is the first major catalyst in the cascade of hypertension. Angiotensin 1 gets converted by ACE to angiotensin 2, and angiotensin 2 is that powerful vasoconstrictor. So think about these meds as we mention them. Think about these classifications as to what we're doing and where we're interrupting this cascade. So this angiotensin 2 is a powerful vasoconstrictor, and we give meds like, say, lisinopril or ACE inhibitors to block this along the way. Once angiotensin 2 vasoconstricts, this thing tightens up the arterioles and increases the vascular resistance, and the heart now has to pump harder, right, with angiotensin 2 floating around unchecked. This triggers a release of aldosterone from the adrenals. Aldosterone triggers a release of antidiuretic hormone, which is vasopressin, from the pituitaries. And what this does is it tells the kidney to hold on to salt and water, okay? And potassium drops. So what happens is you have this situation where the kidneys have said, we're not getting enough, start this cascade of events in order to raise the pressure so we do get enough. So the more water and sodium that gets retained, the more preload we have, the more volume it goes up, and the higher the pressure goes. So what we do to interrupt this is we give something to block the aldosterone, like spironolactone. And the reason we do that is so then you don't stop holding water and salt, and we also start saving some potassium. So when the RAS is overactive, whether it's from genetic factors, kidney disease, chronic stress, this leads to too much vasoconstriction, too much fluid retention, sustained high blood pressure, and then many of the antihypertensive drugs are just aimed at all of the different levels in that cascade. ACE inhibitors, ARBs, aldosterone antagonists, And each of these are things that will helpfully bring the pressure down. There is another way that you can develop hypertension, and that is endothelial dysfunction. So the endothelium is this single lining inside every blood vessel, and it's active and it's a dynamic organ, and it releases hormone, endothelin. So what happens is if you disrupt that endothelium, you trigger an inflammatory cascade, including platelet activity and inflammation. When it's healthy, this balance is maintained and the blood should flow smoothly. But when you have dysfunction, something interrupts it. This is like the earliest sign of hypertension. Why are we worried about it? Because you're pumping, eventually that wear and tear affects the blood vessel, and this triggers this cascade of events in which we have reduced nitric oxide. Nitric oxide acts like a vasodilator. It makes them supple. We want supple vessels. We want them to dilate and constrict. We don't want them stiff. So nitric oxide is produced by the endothelial cells through an enzyme called endothelial. This diffuses into the smooth muscle layer of the vessel wall, and it tells it to relax, and it causes vasodilation. But when nitric oxide levels fall, whether from aging, smoking, high LDL cholesterol, this vessel cannot dilate effectively. So that increases the vascular resistance, and as a result, that afterload goes up and your blood pressure goes up because the heart has to pump harder. So you can think of nitric oxide as the vessel's peacekeeper, but when it's gone, the tensions just rise. And when the tension rises, the penis falls. Why would I say that? Because that's one of the only things that will get men into primary care, who are the largest population of cardiovascular patients. Erectile dysfunction is the leading complication of untreated hypertension. And it's interesting because the treatment they're using, sildenafil, releases nitric oxide. It's a vasodilator because you need it to dilate. So if there's too much vasoconstriction and prolonged hypertension, that leads to these end organ damage. So the second step in this endothelial dysfunction, at the same time, the balance is shifted towards this endothelium. And endothelium is a vasoconstrictor also, but the problem is you have less nitric oxide to open the vessel, so it tightens more. So what happens is there's a double hit of vascular tone setting the stage for chronic vasoconstriction. So at the end of all this, before the inflammatory cascade is complete, it triggers this cascade of oxidative stress, and this becomes a perpetuating cycle of dysfunction. So the more overproduction you have of reactive oxygen species, then you have more free radicals inactivating the nitric oxide that you're trying to provide. That leads to more disruption, and then you have more nitric stress. And so you have this cycle that's kind of perpetuating. This causes this chronic low-grade inflammation, and then the cytokine surge. Remember interleukin-6 and the tumor necrosis factor? All of those are released, attracting immune cells that infiltrate the vessel wall. This inflammation thickens the intima, promotes lipid deposition, and increases the stiffness. So you can see what was initially a compensatory mechanism has now become a perpetuating factor in promoting this hypertensive situation. Now, the final reason we can have hypertension is due to increased sympathetic nervous system tone. This is the fight or flight. This is under normal conditions helps you maintain your vascular tone and cardiac output when the big bear wants to come eat you. But if this is chronically overactivated, maybe you're living in a stressful environment constantly, this is like living with the foot on the gas pedal all the time. This keeps the body in a constant state of arousal. So it's like, you're constantly on edge. This is manifested by increased heart rate. And you will notice that there's increased norepinephrine in the system, increased vasoconstriction. And so the immediate result is obviously this increased cardiac output and high blood pressure. But over time, you're really increasing the wear and tear on the heart. So norepinephrine binds to the alpha-1 receptor on vascular smooth muscle. This triggers the vasoconstriction, which increases the systemic vascular resistance. When the vessel constricts, the heart has to pump much harder against that vessel. So this is what you call increased afterload. This sustained afterload puts a perpetual mechanical strain on the left ventricle, which promotes hypertrophy, and that's how you can see on the EKG LVH findings. The other thing that happens, oh, this is the thing that's responsible for baroreceptor reset. This is what gets them used to the high blood pressure in the carotid sinus and the aortic arch. You get used to these high blood pressures, so it stops perceiving this as an abnormal finding. So the problem is if you then drop the pressure too soon, it thinks that this high pressure is what is normal. So we don't want that because then it'll be perceived as a hypoperfused state and will trigger other mechanisms. So we try to bring the pressure down gradually. Sympathetic nerves also innervate the kidneys, and they can also stimulate the renin release, and that also triggers the renin-aldosterone system, and that's where we get into this cardiorenal cycle of hypertension. And then finally, over time, a condition called vascular remodeling happens, in which the hypertrophy of the smooth muscle becomes the new normal state. And of course, if something is bigger, what does it need? It needs more oxygen. So you wind up perpetuating that cycle. Okay. So if hypertension is just high pressure, why does it kill people? Because this constant pressure is reshaping the pipes. It's increasing myocardial demand. You're building thicker wall muscle. So the LV is trying to pump hard. It's growing. It requires more myocardial perfusion, which it's not able to do. In the brain, you might get small vessel ruptures, microvascular ischemia. In the kidneys, you get glomerulosclerosis. The kidneys are hypoperfused. You see albumin leaking. In the eyes, you get AV nicking. So this is a unique finding. This is ultimately what you're looking to happen. And if you realize it doesn't happen over time, it gives you that urgency to say, look, we really should treat your blood pressure. We really should encourage lifestyle. We really should bring the pressure down. There's a unique finding in the elderly. The elderly develop this thing where the systolic goes up and the diastolic doesn't follow. This is called Windkessel effect. This is the ability of the large arteries to act like elastic reservoirs gets lost. So in a healthy young artery, the vessel wall is able to stretch during systole and it recoils during diastole. And this cushions that pulse wave, maintaining the steady flow. But in older adults, the arteries become stiffer and they don't recoil as much. So those vessels can expand and they don't expand and recoil in the same way. So that's why you may notice a 160/70, a pretty wide pulse pressure. Okay. So when a patient says to you, I have heart disease, what is the thing you're trying to figure out? What does that mean to you? I have heart disease or I have chest pain. Well, it could be heart disease, right? And by heart disease, you mean there's some sort of mismatch between oxygen that's demanded and how much is being delivered, right? So that is typically what we're afraid of. We don't just say it's reflux, have a nice day, take a Pepcid, right? The main thing we need to focus on is oxygen supply and demand. The heart is greedy for oxygen, and ischemia means that there's a balance against that supply-demand situation. So the way it's supplied is either a plaque has ruptured, a fibrous cap tears, platelets rush in, a clot forms, and suddenly a 50% lesion can become 100% occlusion, right? That's one way that can happen. Clot can form. Another way it can happen is through vasospasm. You've heard of Prince Meadows angina. Well, this is a situational, temporary choking off the supply to the heart. This is more common in unstable angina, but also in cocaine-induced heart attack, right? They're young, they're doing the cocaine, it's not quite ready for a plaque to form, but they've caused a vasospasm that has temporarily interrupted perfusion of the myocardium. So that's a vasospastic ischemic situation. Microvascular dysfunction means that even open coronaries can't deliver the necessary oxygen. Either a clot has formed or something has impaired the flow. Now, what raises the demand? What does the body do when it senses stress? Well, it gets tachycardic. Why? Because I need more, so it circulate what I got. But that in and of itself also raises the demand. So then you get initially hypertension, and over time, left ventricular hypertrophy, and over time, you get wall stress and more oxygen demand and more oxygen hunger and inefficient supply. And that's what we're talking about when we talk about things like acute coronary syndromes. So we got three coronary syndromes to talk about, right? We have stable angina, unstable angina, STEMI, and how do we tell these all apart? Well, stable angina is this. I exercise, I have chest pain, I rest, it goes away. Stable, routine, predictable. I have a treatment. I get stressed, I get chest pain, I calm down, it goes away, stable angina. We know what to do. We encourage exercise to the point of pain, then stop, walk again till pain, then stop, and we build your tolerance over time. And we can do conservative management with that. Unstable angina means this plaque has ruptured and I'm not doing anything and I wake up with chest pain. Unstable angina. That's a problem, right? It's not the daily demand that's causing it. It's like no demand is now causing me to have it. That's the unstable angina and the non-STEMI. Now, when you have a non-STEMI, meaning non-ST segment elevation MI, that's what I mean by non-STEMI, the plaque ruptures and there's usually a subtotal occlusion. The troponin may go up in a non-STEMI, but not in unstable angina. And that's the distinguishing factor. Did you break and leak enzyme? Unstable angina versus NSTEMI. NSTEMI, you're having a heart attack. You've leaked troponin. The other thing to keep in mind is the symptoms will escalate in both unstable angina and non-STEMI. Unstable angina can progress to the non-ST elevation. And then finally, the ST elevation MI, this is the total occlusion. You get transmural ischemia. You see an ST elevation. You need rapid reperfusion. This is the one that they're rushing to the cath lab, hopefully within like under an hour. But if we're not going to get to the cath lab within 2 hours, this is the one that they're going to thrombolyse. So chest pain is never just chest pain. You always want to figure out the supply problem or a demand problem or both. And that's the single question that helps you figure out how are we going to treat this. If it's a demand problem like unstable angina, okay, rest. If it's a supply problem, let's reperfuse. So when a patient with acute coronary syndrome rolls in, your immediate priority is two things. Number one, you want to relieve the ischemia, restore blood flow. And two, you want to make sure they're hemodynamically stable. So the first line, this is where you get into your MONA, you've heard of MONA, or your morphine, oxygen, nitro, aspirin, aspirin to platelet aggregation, beta blockers to control the heart rate. Interestingly enough, a new study came out. We used to put people on beta blockers thinking we're promoting longevity and promoting well-being and we're reducing cardiac demand. There's a large European study that came out and said, turns out it doesn't actually do that. Suffice it to say, it's still the standard of care here, but you should know that it's no such thing as settled science. Every few years, you get a new study with a larger group of patients, and you can, modify what we do. I mean, look, we're not bleeding people anymore, so we've come a long way. Okay. So you will see on this slide here that there's a bunch of scores. You see this risk stratification by perfusion there. There's TIMI, there's GRACE, there's Killip classification. Suffice it to say, these are all different calculators that will help you go through and systematically stratify the patient to determine what level of risk this patient is. If you don't work in cardiology, this is not going to be your bag of tricks. My hope for this class is basically to get you ready to float. You don't know where you're going. You don't know what you're doing. You just have enough information to speak the language, enough to learn and orient to this specialty if you decide you want to wind up there. So it's meant to be general, not as deep as it would be if you made this your subspecialty. And it's not uncommon. A lot of adult geri and family practice do wind up in subspecialty areas. Okay, let's talk about ischemic heart disease and advanced pathway complications. So we've talked about ACS, plaque rupture, thrombosis, ischemia, but it doesn't stop here. The next problem we have to contend with is what happens after the heart attack. So this is why we recover them in the CCU, because you can have some severe complications. And these severe complications can be mechanical, electrical, or hemodynamic. So the first is the mechanical complications. This is where structures in the heart, because they were hypoperfused, can tear. So papillary muscle rupture, ventricular septal rupture, free wall rupture. These are big to-dos, and they happen usually within 2 to 7 days post-MI. So that's why we want these people who look calm and cool in the CCU and look like nothing's happening, and it all of a sudden goes to death. Because this is why. They could rupture a muscle, and that's kind of bad, because they likely ain't going to survive. The other thing you need to think about is electrical complications. The problem with electrical complications is you have to be looking. So there's no looking in the population. You need them on that cardiac monitor because all of a sudden you're a stable patient. Look at them going right into VTAC and I was trying to go to lunch. So that doesn't help. You have to get the code team and zap them. But they're very high risk, especially within the first 48 hours post-MI. And then there are bradyarrhythmias and AV blocks. So I did psychiatry in a homeless shelter, and a man sits in the chair and he says, I'm just here to have my Zyprexa lowered. And he's just breathing, but he's making more noise than I'm used to him breathing. And I feel his pulse, and well, I don't feel a pulse, but he's talking to me, so maybe I'm insensitive. So I check the other hand. I'm like, okay, I know how to check a pulse. So I just felt it longer, and there's just no pulse. I'm like, but the man is clearly awake and he's talking to me. So I pull out my stethoscope and I listen to his heart, and oh, thank God there's a heartbeat. Well, why is there no pulse? So the man says, is it bad? I said, it's always bad if a psychiatrist pulls out a stethoscope. So then there's this concept of the pulse deficit. So I'm listening to the heart and feeling the pulse like, oh, not every beat is conducting. Wow, his heart rate that I'm hearing is like 30. The pulse in the wrist has nothing to do with the heartbeat. What was he in? Complete heart block. Psychiatry, complete heart block. I'm like, what the hell is this? Excuse me, can you please call 911? Thank you. Hi. And who am I working with? Social workers, case managers. Nobody's grasping the gravity of the situation. He looks fine. Please call 911 right away. You'll be just fine. I just need to go to my room and do my... No, 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 no. You don't need to go anywhere or do anything. 911. EMS walks in. Hi. What's the problem? He needs to go right now. Well, we're going to put him on the monitor. Oh, good. I want to see what this looks like. And sure enough, heart rate of 30, the atria is not talking to the ventricle. I get a call from the ER. We're floating a transvenous pacer. He's on his way to CCU. Within an hour from my office to the CCU. That was good. Good thing I brought a stethoscope that day. But suffice it to say, you can't forget this. So even if you're going into psychiatry or not doing acute care, people present with acute care problems all over primary care. So just keep that in mind. So, well, I don't get involved in that now. It's my office. I don't get too involved. You know, I'm just like, I'm doing homeless shelter mental health is what I was doing at the time. He's in the CCU with the transvenous pacer. EP could be at lunch. I don't know. We're just buying time, really. We need a transcutaneous pacer, and that's mean and painful. Also, they're nervous because he's on antipsychotic. So, like, is he going to start wigging out on us? I'm like, no, he's fine. Okay. So, ischemic heart disease at its core, this is all about getting enough oxygen to match what is demanded. The myocardium needs oxygen and nutrients. The coronary blood flow can't keep up, either because the demand is too high, like in tachycardia or LVH, or the supply is too low, as in atherosclerosis, anemia, or hypoxia. So, what does this translate to acute coronary syndromes? Well, that is acute coronary syndromes, right? I mean, obviously, you're not getting enough. That's the problem. Another factor that people tend to forget about. So this is missed a lot unless you actually work in cardiology or you work with a transplant population. But in the acute phase, there's a factor called reperfusion injury. And reperfusion injury is a phenomena that develops as a result of oxidative stress. The sudden oxygen rush triggers reactive oxygen species, which then gobbles up nitric oxide. See, that's the problem. This is due to this compensatory mechanism. And essentially, you realize they didn't get to hypoperfusion overnight. They've gotten accustomed to it. So whenever you flood in with a good therapy, there's always going to be a risk of downstream reperfusion injury. So another manifestation is this calcium overload. So ischemic cells accumulate calcium, and reperfusion amplifies this. So what happens is you get this hypercontracture and cell death because calcium is suddenly leaking out of the cells. And then another factor of reperfusion injury is mitochondrial dysfunction. That's when the reperfusion causes mitochondrial permeability, and this leads essentially to the collapse in the production of ATP. And then finally, of course, everything goes back to inflammation. This is when neutrophils flood in and worsen the injury. The problem is this can trigger things like arrhythmias, something called myocardial stunning, which is a transient contractile dysfunction despite low flow. And it can also cause microvascular obstruction. And then further necrose the tissue. So the problem is, what do we do about this? We don't really have a choice, because if we don't reperfuse you, you're going to die faster. Life is trade-offs. You may get reperfusion injury. You may die from the reperfusion injury. But what was our alternative? To let you die from no perfusion? So this is the tightrope we have to walk. There's a lot of research in this as to what to do. Some are thinking antioxidants. Some are thinking other types of meds. But there's really, it's all clinical trial stuff at that point. But suffice it to say, it's here so you're aware that this problem can exist even when you do all the things right. Okay, I think we should take a 10-minute break and then we'll bring you back. And here we go. You seeing the slides at home? Thumbs up if you see the slides. Good. So what we're going to talk about now is heart failure. And there are these two concepts about preserved versus reduced ejection fraction. So there are two broad phenotypes, and I want you to know how to separate them because this is all the rage and we talk about them. It's not to say one is better than the other. They're just different. So by ejection fraction, we're talking about the underlying mechanics. So the first one I want to tell you about is heart failure with reduced ejection fraction. Now, what we're talking about here is the number 40. So 40 and below in the EF, that's what we're calling reduced ejection fraction. What's broken here? In this case, it's the pump cannot squeeze. The contractility is impaired, usually because of ischemia or infarction or like dilated cardiomyopathy. The ventricle dilates and they develop eccentric remodeling, and then the EF drops below 40, the stroke volume falls, and congestion rises. That is reduced ejection fraction, 40 or below. The other side of this is preserved ejection fraction, so heart failure, PEF. What's broken here is the pump cannot squeeze, but the pump can squeeze in preserved EF. The pump can squeeze fine. The problem is it cannot relax. So when the ventricle is stiff, it develops a thick wall. What can cause this? Well, this is your untreated hypertension for a long time, leading to left ventricular hypertrophy, aging, obesity. The ejection fraction on the echo will look normal. It'll say EF 50% or greater, right? EF 65%. But the filling pressures are high and the diastolic reserve is gone. Patients become breathless with exertion. So what they share clinically is they will both present in the same fashion, dyspnea, fatigue, orthopnea, edema. From the outside, they both look like heart failure. The way you're going to distinguish it, though, is you're going to need an echo. So preserved ejection fraction does not mean preserved function. Heart failure preserved ejection fraction is just as disabling and deadly as the reduced ejection fraction, but the diagnosis requires the echo plus a clinical correlation. So with reduced ejection fraction, it's a weak pump. With preserved ejection fraction, it's a stiff pump and difficulty relaxing. Both leave the patients drowning in congestion, but the patho is different. Okay. So when we talk about heart failure, we said this begins with a failing pump, but it also can become a systemic disease process. Remember, I told you, is it the system affecting the heart or the heart affecting the system? Well, in this case, I'm talking about the heart affecting the system. So the cycle, because the body's compensations dig this hole deeper, dragging other organs alongside it. So cardiac output due to increased SNS, the RAAS system, ADH activation, increased afterload, increased preload, remodeling, leading to reduced cardiac output even further. The ventricle spirals down and every organ downstream takes a hit. So in the pulmonary system, for example, you may have pulmonary venous pressure increasing. And then you'll see things like pulmonary edema, dyspnea, orthopnea, PND, and poor gas exchange. Which, by the way, I'm going to pose a question out there, and then you can type your answer online. What's the difference between an artery and a vein? Please think about it before you answer. Don't answer now, but it really helps if you have this clear in your mind. Oh, and if your answer has anything to do with oxygen, it's wrong. So perish that thought altogether. So now think about what is the difference between an artery and a vein, especially when you go home and try to track the blood flow through the heart. Okay. Another thing in terms of end organ damage is the kidneys can become affected through a low perfusion state. The RAS firestorm begins. You have this cardiorenal system that ensues, and this perpetuates the problem. Liver congestion. You can get heart failure cirrhosis, right? Cardiac cirrhosis, they call that. Or skeletal muscles can break down as well because the body's going to start trying to use that protein for energy, and they get this cachectic look about them and they're just fatigued and drawn. And then, of course, the brain can be affected. This is those hypoperfusion states. So when you see edema, confusion, rising creatinine in a patient with heart failure, don't call these comorbidities. These are just natural extensions of this same disease process. Okay. This is not separate conditions. They're all related downstream effects. It causes multi-system organ dysfunction. So take a look at this case here. The history of dyspnea, exertional orthopnea, fatigue, edema, weight gain, nocturia. And this is what some of the findings may indicate. And you may do echoes on this person and you may notice like the BNP is elevated. Now, BNP is going in and out of favor, by the way. This is a release of increased myocardial stretch. In the hospital, like, why'd you do that? In the community, it's like we didn't really have another choice. We did a BNP. So in the community, they're more accepting of it, but it's really meant to build a clinical picture as to the level of severity. The way heart failure is actively diagnosed is you start with the story, confirm it with the exam, and then use labs and imaging to support what you already suspected. Don't go on a fishing expedition. So what the patient may tell you is I have dyspnea on exertion. I need 3 pillows. I get paroxysmal nocturnal dyspnea, edema, weight gain, nocturia, fatigue. And on the exam is where you're going to see things like the tachycardia, narrowed pulse pressure, JV, jugular venous pressure's up. If anyone's listening to hearts anymore, you could hear an S3 heart sound. And the elevated BNP, chest X-ray can show cardiomegaly. Basically, what you're seeing is all of these end stages of congestion. So someone asked the question in the break, well, how do you know what to start in the office? Like with heart, you need to know which lever to pull on. Well, if you come in and I find you're hypertensive and I don't see any edema and your lungs are clear, right? And your heart rate is normal, I know the problem is probably afterload. So I need to afterload reduce you with a calcium channel blocker or an ACE. But if I check you out and find that you're tachycardic and hypertensive and there's no peripheral edema and the lungs are clear, well, then maybe I need to bring your heart rate down with a beta blocker or a calcium channel blocker. Calcium channel blocker gives me a 2-for-1 to bring the heart rate down and open up the vessels. So that's kind of how you can decide which way you want to go with the situation. Eventually, you can get the echo and the ultrasound and the EKG to see what exactly the end organs are looking like here. So take a look at heart failure and this core clinical management. So this is a neurohormonal condition, right? Because of all the neurohormones that are involved here. And if you target the right pathway, whether it's the RAAS or the angiotensin pathway or the sympathetic tone, this is going to help you get to the bottom of the problem. So these are 4 different presentations of heart failure. So if they are wet and warm, you may see congested with adequate perfusion and treatment with diuretics. If they're wet and cold, this is a congested person with hypoperfusion. This is the one that's in the ICU, by the way, wet and cold. So this person's going to need some inotropic support. Dry and cold, this is a hypoperfused person without congestion. So this one's going to be in the ER because they need fluid volume resuscitation. And if they're dry and warm, this is compensated and you can treat these ones in the office. So we have a list of cardiomyopathies here, okay? And then after this, we're going to get into the arrhythmias and we'll talk about some kids. So let's talk about cardiomyopathy. So these are different types of heart failure. The first one I want you to pay attention to here is dilated cardiomyopathy. This is ventricular dilation with impaired systolic function, impaired contractility. Systolic function is contractility. Why do they have this? It can be because of ischemic heart disease, alcohol, viral myocarditis, toxins, genetics. These are the various factors that can cause it. And what happens in this situation is you have reduced contractility, which means you have low stroke volume, the ventricles dilate, you get eccentric hypertrophy in an effort to preserve output, but this increased wall stress increases myocardial oxygen demand. So what happens is you have a high preload, and then that leads to pulmonary congestion because it's not able to pump out of the heart. If it doesn't pump out of the heart, it backs up into the lungs. The afterload is increased because the stroke volume is low, so the RAAS system has been activated because the kidneys are sensing a hypoperfused state, so it's increasing vascular resistance, so that left ventricle has to pump more in order to perfuse those kidneys. This person is at high risk for arrhythmias because of that stretched myocardium. The clinical consequence here, this is the classic cause of heart failure with reduced ejection fraction. The other one, and this is important because this will hit your seemingly healthy athletic teenagers. This is the thing that causes sudden cardiac death, either in practice or at the finish line. This is a genetic disorder, often autosomal dominant of a sarcomere protein. This leads to asymmetric septal hypertrophy, plus or minus a left ventricular outflow tract obstruction. When I say left ventricular outflow tract obstruction, what am I talking about there? What is the thing that might be obstructed that comes out of the left ventricle? Where does the blood go after the left ventricle? The aorta, through the aortic valve. So something there is obstructing the outflow tract. So this leads to a thickened, stiff ventricle and diastolic dysfunction, meaning the heart cannot fill. You get outflow obstruction, worsens with decreased preload. So athletes that are dehydrated make the situation worse. And they'll say, oh, I'm a little lightheaded. Yes, because I'm dehydrated. Or you have a left outflow tract obstruction that we have not yet picked up. The decreased afterload, they have increased contractility in an effort to compensate. These people need an adequate filling volume. So first line for these people is to fill them up in an effort to increase the cardiac output. These are afterload dependent, so they tolerate higher afterloads, and then they tolerate a higher afterload better than a sudden drop. Because why? Over time, the body tries to accommodate whatever dysfunction is going on. So if they have that left out tract obstruction, the body's just like, oh, this is what we need to do to live. Okay, pump, pump, pump harder, pump harder. And so it just kind of gets used to it. So the problem becomes whenever you suddenly fix something, you can cause something to be worse. So contractility can worsen the obstruction if you increase it. These people are at high risk for ventricular arrhythmias. These are the ones that develop sudden cardiac death. Their symptoms will be dyspnea, syncope with exertion, a harsh crescendo decrescendo murmur that gets better with squatting. Why might squatting make it better? What happens when you squat? You increase vascular resistance, right? Because you've made it harder for the heart to pump. If I squat down, you increase vascular resistance. Okay. The final one here I want to talk to you about is this restrictive cardiomyopathy. This is a stiff, non-compliant ventricle due to infiltrative or fibrotic process. Underlying conditions that can cause this are like amyloidosis, hemochromatosis, sarcoidosis, radiation, maybe if they had breast cancer radiation and they irradiated the ventricle, and endomyocardial fibrosis. This is a diastolic dysfunction. The ventricle cannot relax. There's impaired filling here. The preload requires a higher filling pressure, so the atria may be enlarged. Afterload usually normal, but systemic venous congestion is prominent because you have fluids backing up. Contractility is often preserved early on, but eventually, like all heart failure, contractility will take a hit. And eventually, all paths will lead to death in the same way. The organs stop functioning. So signs of right-sided heart failure. So this is something you should be able to easily distinguish. Right-sided heart failure is going to manifest by fluid in the periphery, right? Everything to the right of the vena cavas, right? So JVD, hepatic, pedal, etc. Left-sided heart failure, where does that back up into? The lungs. So that's where you get your pulmonary edema. So that's your clinical way to distinguish between the two. Can one lead to another? Eventually, yes. You can have heart failure, complete heart failure on both sides. Okay. So summarizing these heart failure, dilated, that's a weak stretched pump. Hypertrophic, that's a thick, obstructed pump. Restrictive, that's a stiff, infiltrated pump. All of them carry risk for arrhythmia, and some of these people will be considered for implantable cardiac defibrillators. All right, let's talk about AFib, the gift that keeps on giving here. So atrial fibrillation develops because of a combination of electrical and structural abnormalities. And this creates the substrate for chaotic atrial activation and irregular ventricular response. So there are some main functions here that we need to talk about. So first, pulmonary vein triggers. The pulmonary veins aren't just passive conduits. They contain myocardial sleeves capable of generating an ectopic foci. These foci can fire premature atrial contractions that act as the initiating spark for an AFib episode. So in other words, AFib can often begin in the pulmonary vein, which is why ablation strategies tend to target that area. Interestingly enough, you can also have an increased risk of AFib in someone with, say, COPD who develops cor pulmonale because there's higher congestion in that pulmonary vasculature. The next thing that happens here is electrical remodeling. So the more AFib you have, the longer you're in it, the more likely you are to be in it. So over time, the atria undergoes a change in ion channel function and shortens the atrial refractory period. That means the impulse can re-enter tissue sooner, promoting multiple re-entry circuits. This is the one where it looks like VTAC on the screen until you do the 12-lead EKG, and then you say, oh, that's AFib with aberrant re-entry, because you're able to see more leads in the heart. You'll also see abnormal calcium channel handling here, which increases this triggered activity after depolarization. The characteristic thing of AFib is it's irregularly irregular. You can't really pick out P waves. And the concern is when the rapid ventricular response follows it. Then you get structural remodeling of the heart. Cardiac chronic stress, hypertension, inflammation can cause atrial dilation and collagen deposition. This fibrosis acts like scar tissue. Well, this scar tissue interferes with the internodal pathways, and so this can create opportunity for other ectopic foci to start firing. So what you have now are multiple small re-entry pathways that can fire simultaneously, and so you have a lot more risk for this aberrant conduction. That's why long-standing AFib is hard to reverse, because the structure itself becomes the problem. I mean, you could completely ablate all the AV nodes, but then they're going to become 100% pacer dependent. What happens hemodynamically and functionally is when the atria loses that coordinated contraction, preload drops by about 15 to 30%. We call that the atrial kick. When that atrial kick is responsible for 30% of cardiac output, that's a big deal, especially if you're operating from a position of not a lot of physiologic reserve. This irregular RR interval is what's called variable ventricular filling. So sometimes you really fill the ventricle and other times not so much. Well, what's happening is that blood is stagnating and coagulating there, and you get one good cardioversion or one good pump, and you fire that clot to somewhere in the brain, the lungs, the legs, the kidneys, the mesenteric artery, somewhere, and now that you are high risk for emboli. This is one of the primary underlying factors in multi-infarct dementia. They can get mini clots, not enough to have lasting symptoms. You're like, where did this come from? And you do the EKG and you look like all these old chronic ischemic changes. Well, this is kind of where it comes from. Now, you could have AFib and resolve the AFib, and no one will ever know you ever had AFib, especially if it happened overnight and you slept through it, right? Because nobody sleeps with them. Oh, now our watches tell us everything, but I don't wear one of those watches. So if I have AFib and die in the night, no one will know. Clinically, this is why patients will say they feel fatigued, dizzy, short of breath, because they don't have that atrial kick and they're not hemodynamically compensating. So AFib is sustained by both electrical instability and structural remodeling with real hemodynamic consequences. Who are these people coming to class late now? Okay. All right, so let's talk about once AFib starts, what keeps it going? Well, it's not just about the initial trigger, it's about the atrial environment that sustains it. So these re-entrance circuits, the electrical remodeling, the structural remodeling, these are the things that keep this thing going. Thromboembolism risk in AFib, blood stagnates in the left atrial appendage. That's what predisposes you to clot formation. And these clots can embolize, like I said, anywhere in the body, but most severely to the brain. But I don't know, pick a part. Which part do you want clotted off? It's generally bad. Tachycardia-induced cardiomyopathy. This is another trigger for it. When the ventricular rate is uncontrolled for a prolonged period of time, this constant tachycardia can cause myocardial dysfunction. This leads to heart failure with reduced ejection fraction, and it's often reversible once you control the rate. So that's why we put a lot of emphasis on rate control with atrial fibrillation. In the elderly, we worry most about stroke risk. Drug sensitivity is huge. And then the confounding problem here is, do you anticoagulate them? And then their high falls risk. So what do you do here? So this is a conversation I have several times a week. Is it worth the risk or not? You're 89 years old, you're newly in AFib, you might fall and break a hip and bleed into your head. You don't want this resuscitation attempt. So this is the conversation that needs to be had. Okay. Yeah, absolutely. Yep. Those device implants and to catch the clots and that sort of thing. Yeah, absolutely. It's come a long way. So this is AFib, and these are some scores. So determining who to anticoagulate and their various risk factors, they use this CHA2DS2-VASc score to estimate what is your thromboembolic risk. Each letter corresponds to a risk factor. So C is for CHF, H for hypertension, A2 for age greater than 75, D for diabetes, S for stroke prior TIA, V for vascular disease, another A for age, and then sex, female sex. If a man scores 2 or higher, or a woman scores 3 or higher, that's who's getting anticoagulated. So, but you can see how many ways you can score into this algorithm. Remember, stroke is similar whether it's AFib or paroxysmal or permanent. Your stroke risk is the same. So even if you're just having brief episodes, you still would have to do the screening criteria to find out, do we need to anticoagulate you? There's another test that they do alongside this. It's called the HAS-BLED. This is another rule because the problem, of course, is what is your risk of not only stroke prevention, but we want to know about bleeding risk. So you'll do the CHA2DS2-VASc score with the HAS-BLED score, and this will tell you how likely am I to anticoagulate you. So you're balancing stroke prevention with bleeding risk. H is for uncontrolled hypertension, A is for abnormal renal or liver function, S is for previous stroke, B is for bleeding history, L is for labile INR, and then E is for elderly over 65, and D is for drugs or alcohol use. So if you have a 3 or more score, you need to address those modifiable risk factors. And if you can't get the score under 3, then that's the one you're probably not going to anticoagulate because the risk of bleeding outweighs the benefit of clot prevention. So that's how you can use CHA2DS2-VASc with HAS-BLED to decide how do you want to treat this person. So that's what makes this great fun for all parties involved. Another one coming in late. Okay, so let's talk about this arrhythmia that upsets everybody. So if you're in psych, this is for you because this is our live and die by this. All of our drugs cause this to get deranged. This QTC, this represents what? Ventricular depolarization. That means this is the vulnerable period of the heart where if you fire another impulse, we're going to set the stage for torsades or VTAC or VFib. So we don't want that. It means we don't want a long vulnerable period. We don't want a long QTC. Essentially, how long the ventricle stays electrically active. So what does it mean if it's prolonged? It means that repolarization is delayed. This delay makes that cell membrane unstable and prone to early after depolarization. Little sparks during repolarization can set this cascade off for polymorphic VTAC or torsades, and that's very bad no matter what setting you're in. So what counts as prolonged? Look, it's different based on men and women, but in general, over 500, that's unnerving, and that's what sets the stage for torsades. So you need to look at this from a situation of, is this a congenital problem? Because you can have congenitally prolonged QT. A lot of times this is drug-induced. A lot of medications prolong this. There's a website called QT Drugs, and you can just Google QT Drugs, and then you can just type the drug in there, and it'll say, yes, it prolongs. But basically, most of the the antipsychotics and a lot of the psychotropic drugs will prolong the QT. Also, a lot of opioids will prolong the QT. So you have to be careful. Antibiotics can prolong the QT. Zithromax was big during the COVID pandemic. Now, keep in mind, you're on an antipsychotic, you get sinusitis, someone throws you on a Zithromax, boom, 2 QT prolonging drugs, drop dead from VTAC, right? Not uncommon. It happens. So you have to make sure that you are doing a medication reconciliation every time you see the patient. In psychiatry, I say, have you seen any other prescribers since you've last seen me? Have you started or stopped any other drugs or supplements since you've seen me? It's only been a week. Have you been to the urgent care or the gynecologist since you've last seen me? Why gynecologist? You know what those people do? Those people put people on diflucan. Do you know what those people do? Diflucan, one and done. The patient doesn't know that they're on a pill anymore because it's one and done. Do you know the half-life of that pill? Over a week. Do you know what happens? Is it inhibits the metabolic pathway that my antipsychotic goes through. Know what that does? Raises the level of the antipsychotic and raises the risk of acute prolongation and death or sedation. Horrible. But they don't think they're on it because they took it one and done. I'm no longer on it. So that's why you got to be very careful doing your medication reconciliation. Whenever you look at drugs, look at half-lives. Yes. Zofran can also prolong QT. The problem with Zofran is when they give it with an SSRI for nausea, because it's the most common side effect, the big concern there is serotonin syndrome. I don't find it to be terribly laborious. It really depends on how much you're doing it. If it's a one-time thing, I don't typically see it. Elderly, obviously, it's a problem. If you've just started, it's a problem. But the big concern is the QT thing. Usually it's like Reglan that you're worried about, metoprolol that prolongs the QT. So just be careful there. Okay. So, well, we've prolonged the QT. Now, the other thing we need to worry about here is shortening the PR. This is another problem you can have in conduction defects. So this is WPW. The short PR, less than 120 milliseconds. Who's counting with calipers? Nobody. Everyone's reading it off the printout, and they're reading less than 120 milliseconds because this impulse will bypass the AV node. The other thing I want you to see here is if I stop talking, take a look at this EKG here. This here. This is a normal sinus rhythm pattern, right? This slope, this short PR, that's wrong. This is an AI-generated picture. That's not the PR interval. PR interval is back here. But this little slope here, this is the concern. That concern is the delta wave. If you see that, that's the thing that says, oh, I might trigger my WPW situation there. In WPW, the QRS is less than 120 milliseconds because part of the ventricle is activated early and the rest later, which creates this fusion. Now, it may be sinus or supraventricular tachycardia, but the baseline EKG shows that delta wave pattern. This is a wrong AI-generated picture. This is supposed to be a delta wave, not that. So don't rely on AI pictures, but I tried 10 times and I couldn't draw, so that's what you got. So what makes this so dangerous? Well, the presence of accessory conduction pathways that bypass typical AV node conduction. So instead of all the signals being slowed through the AV node, which is the purpose of the AV node is to slow down the response, the impulse shoots directly from the atria to the ventricle, and it can look like on an EKG, a short PR interval of less than 120 milliseconds. The conduction skips the AV node. You'll see a slurred upstroke at the beginning of the QRS complex called a delta wave, and then the wide QRS due to early abnormal ventricular activation. And so you will see this atrioventricular reentrant tachycardia. This is kind of a big deal. And so this will be handled in electrophysiology. And so what happens is this can come and go. So these are people that come in and out of it. They often get mistaken for SVT, but it's not. This is not just a curiosity, by the way. This delta wave is a red flag. So the next time a patient goes into AFib, this could be fatal because it's too much vulnerability there, because of that rapid ventricular response and other ectopic foci. Okay, so here are some things to consider. So what separates benign from dangerous? Well, it's the mechanism. So always test each one. Chest pain, what makes it a red flag? What makes this a red flag or not is you're going to ask, is this reproducible with palpation or is it fleeting? Is it like Mike's? If it is, that's likely musculoskeletal. I can calm down. But if it's prolonged, say greater than 15 minutes, it radiates to the arm. It has anginal equivalents like nausea, vomiting, diaphoresis. That might make you worried that this is ischemia. You need to err on the side of caution and assume it's ischemia until proven otherwise, because it could be fatal. So supply and demand mismatch is what you're really worried about. If somebody has syncope, obviously this makes it a big deal. A young adult who faints after standing too long with a prodrome and quickly recovers, probably not a big deal. The first guy I ever did a physical exam on, I did a testicular exam, 6.5 feet tall. I'm sitting on the rolly stool, and this naked man just falls down right on top of me, and I'm stuck in the room, and his head's up against the door, so I can't open it to even call for help. Vasovagal syncope, but scared the hell out of me because it was my first one. No one ever said that would happen. So from now on, every testicular, lie down. What? I'm not risking it again. Lie down. I can't be bothered with you falling on top of me, especially if you're 6.5 feet tall and I'm sitting on a rolly stool. How am I going to explain this to the secretary? What did you do? I did what I was supposed to do. He fell on top of me. Call an ambulance, take him out. So vasovagal, not a big deal, but exertional syncope, exercising without warning, someone with a cardiac history, this screams outflow obstruction. So that is a major red flag. Exercise and pass out, red flag. Palpitations. So if it's brief flutters related to like anxiety or coming to class or doing a quiz or taking a test, that's okay. You're allowed to have that. Sustained palpitations. Okay. I had a friend who works with me in addiction who wanted to, and he's going to see this and say I'm talking about him, but I don't care. So what had happened was he felt that he was having palpitations and sweating, and he did not want to go to the ER and be told it was a panic attack. So he did not go to the ER. So I said, well, how long did it last? About 8 hours. You had palpitations for 8 hours with diaphoresis and you didn't want to go to the ER because you thought it was sweaty? He's like, yeah, but I feel fine now. Okay, if you have that again, I need you to go to the ER. Okay, fine. I'll get you into cardiology in the meantime. Well, on the way of doing the renin test that I had him do in the EKG, in the lab, he had his 24-hour urine that I had him do for the catecholamines because you have to look for pheochromocytoma and the like. And I said, he goes, I have my lab that I collected the urine for the last 24 hours, but I'm having palpitations and sweating now. Tell them you're having palpitations and sweating. You need to drop off the sample right now. You can't wait on this line. And then I need you to 911 yourself to the ER. I'm going to take an Uber. All right. From Brooklyn to New York Presbyterian on the Upper East Side. All right. What am I going to do? Argue with him and raise his heart rate more? No. So he came in and he comes to the triage. And she goes, oh, you're going to be so popular. And 8 people came out of everywhere, and the poor man was completely stripped naked, and he was in the CCU within an hour as well. That was also over the phone. Suffice it to say, he went to see electrophysiology, and he's considering ablation and whatever. But, 35-year-old guy was feeling fine, did not want to be dismissed as a panic attack because he knows how horrible the ER can be, and he didn't want to be that guy. But I'm like, if you're having cardiac symptoms more than 15 minutes, go to the ER, okay? Anyone on YouTube more than 15 minutes, go to the ER if you're having cardiac symptoms. But, you can't just say because I'm young, I'm fine. No, young people have problems too, especially with the diaphoresis. Because, well, I can't go, I have to shower first. I'm too sweaty. It's kind of you. Go to the ER. Well, the stickers were never going to stick to his chest. All right. So, okay. So don't just chase single symptoms in isolation. The pattern, the symptom, the cluster plus age and comorbidities and hemodynamic findings. This is the thing that's going to tell you how you can stratify the severity of your patient's condition. All right, let's do some of these questions here. So how do calcium channel blockers and beta blockers affect preload, afterload, and contractility? Which drugs are turning which knobs? Amlodipine, nifedipine, what does that do? There you go. Arterial vasodilation reduces the afterload, minimal venodilation. So the preload is unchanged. It's neutral to slight decreased contractility. Exactly right. What about something like diltiazem and the like? Diltiazem, verapamil, what do they do? What do they work on? Heart rate, right? Good. They bring the heart rate down. They will also kind of have a reduction in afterload, slight vasodilatory properly, but primarily their preload is largely neutral. Beta blockers also, what do? Heart rate, right? They reduce the contractility as well. So that's worth considering there. What about the different hemodynamic profiles between cardiogenic and distributive shock? Is the MAP low? Cardiogenic, what do you think is happening there? Cardiac output up or down? Down. Vascular resistance up or down? Up, right. So that is compensatory clamping. There's high filling pressures. JVP is up. The wedge is up. They're cold and clammy. Narrow pulse pressure. Now, distributive shock. Is the cardiac output high or low initially? High. Initially, it's normal to high cardiac output. And then what's the problem with the vascular resistance in a distributive shock or septic shock? High or low vascular resistance? What's the problem? What do we give the septic shock people? Volume, right? Those pipes are so dilated. So in septic shock, it's low vascular resistance. That's why the cardiac output can sneakily look high, right? It's easy to pump against. So it makes it falsely, it looks high, it looks good. Now, they can have low normal filling pressures. They'll be warm and flushed, wide pulse pressure in late sepsis. Then as they progress, the cardiac output will go down. How do SGLT2 inhibitors improve mortality in heart failure? It's not just the P drugs for diabetes, right? We're just not peeing out sugar, but these SGL2s have actually now become indicated for heart failure. And I'll tell you, these are doing things like they affect the afferent arterial tone, and it causes renal protection because what it's doing is it's enhancing flow directly to the kidney so it doesn't have this perceived low flow state to trigger that RAAS system. The other thing this does is it causes a mild ketone balance, which improves the myocardial energy efficiency. It also reduces intracellular sodium and calcium, and so this helps reduce that excessive contractility that the heart is used to having. And also, it reduces interstitial fluid. So it reduces preload and afterload. So what's happening is fewer heart failure hospitalizations using this SGL2 drug, which is commonly used for diabetes, but, has a benefit here. Pick your favorite one. I'm not doing a drug commercial. You can just look up SGL2 and pick your favorite drug. And, it's the one where you put sugar in the urine. That one. You have to make sure they don't get candidiasis as a result. You know the one I'm talking about. Okay. When is permissive hypertension warranted in acute coronary syndrome? When might you want to keep this thing going? Permissive. What do you think? Yeah, perfusion, right? So if there's ongoing ischemia with hypoperfusion, you want to avoid a precipitous drop in blood pressure because that could reduce also coronary perfusion as well as brain perfusion. So you want to avoid more than 20 to 25% decrease in the mean arterial pressure in someone with a hypertensive urgency emergency situation. Okay, so we call that permissive hypertension. We also do this, interestingly enough, after brain surgeries. A lot of times you'll see this in the neuro ICU. It'll freak you out how high they ride those pressures up, but they really want to perfuse the brain. 220, get them up, get them up. Get those fluids running. They'll run those fluids like it's 500 an hour, 200 an hour, and they don't even blink twice about it. Get them up. And the pee is flowing everywhere, and you don't know what to do with yourself. Yes. 150. Yeah. Oh, no, those are much higher than what you're allowing. So basically, I'm using that as a means of I'm not trying to bring them lower than the 150. But that high number is all going to be about end organ damage. You realize they didn't get there overnight. Yeah. Yes.
The coronary artery, diaphragm.
It increases filling, right? That's when coronary arteries are perfused is during diastole. But I still need systole to get the blood out. I need the blood to leave the heart a little bit. Yeah, it can be, especially in cardiogenic shock. I mean, look, we want the pressure up, right? But that's beyond the other end of the spectrum. But so the whole point of permissive hypertension is to basically say you don't want to take a 220 over 120 person and drop them 50% in the first hour, right? We're not saying permissive as in forever. We're saying hours to days, right? Because look, I can just give you some nitro and down comes the pressure. Then holy crap, I just killed you. That's terrible. We don't want to do that, right? So we say bring it down gradually. Give it time, 25% in an hour for hypertensive emergency. That's what we mean when we talk about permissive. Don't go from like 220 to 120 in a day. Very bad. It's not permissive forever. Okay, let's see here. What is it that determines stability versus instability in an arrhythmia? Like, when do you know, do I cardiovert now or not? Blood pressure, right? So whenever someone says, are they stable or not? That's code word for what's the blood pressure? That's all we really mean. Are they stable? What's the blood pressure? The heart rate's 120. What's the blood pressure? The heart rate is 60. What's the blood pressure? The heart rate is 40. What's the blood pressure? Right? Because my athletes will come in, ooh, his heart rate is 37. What's his blood pressure? Oh, 120 over 80. Right. Oh, he's a runner? You know how those people are. But suffice it to say, that's the distinction. What's the blood pressure tells you stable or not. Okay, so how do we differentiate something like STEMI, Takotsubo, myocarditis, ST elevation? This is all the same ECG headline, three different stories. So how do you tell them apart? I'm going to tell you. So STEMI, regional ST elevation with reciprocal depression on the leads. Abrupt troponin rise, fall in coronary wall motion, culprit lesion in the cath lab. That's the typical STEMI, okay? Takotsubo, this is post-stress trigger. This is what's called broken heart syndrome. This is due to catecholamine surges. They get this apical ballooning and a basal hyperkinesis on the echo. So you need an echo to diagnose this. These people typically have clean coronaries and the troponin doesn't go too high. Myocarditis, this is the I had a cold or a viral prodrome. They get systemic inflammation, diffuse ST elevation in no specific pattern, right? And elevated troponin, but mildly. And, so they don't, the coronary arteries in this would also be clean as well. Now, these people don't have to go to the cath lab for clean coronaries. They can do CT angios on them. They can do CT scans, MRIs, that sort of stuff. That's a nice way to tell that as well. Let's see here. Which hemodynamic parameters guide management of pulmonary edema? How would you manage pulmonary edema? So what's the big thing we said? What tells you if you're stable or not? Blood pressure. So blood pressure. So hypertensive with pulmonary edema, they need afterload reduction, right? So if you're hypertensive and I hear RAAS, that's the person that's going to need nitro. All right. What about normotensive? If they're normotensive with pulmonary edema, that's the one that you can give the diuretic to. Okay. Hypotensive with pulmonary edema. Well, right, but that is you want to avoid and also avoid the vasodilators as well. Yes, exactly right. Right, right. That's not going to sit in the office long, out the door, right? Got it. And then also, all right, that's good enough. We're not going to do hemodynamics anymore beyond that. Okay, so we have a case here, rapid hemodynamic assessment framework. Okay, we did this. The warm and dry, that's compensated state, adequate perfusion, cold and wet, cardiogenic shock, warm and wet, classic heart failure. You can manage them right where you are. Permissive hypertension, when not to lower the blood pressure in acute stroke, acute coronary syndrome with hypoperfusion. Signs and symptoms of multi-system involvement, Kussmaul's breathing, muffled heart sounds, pulmonary edema. All of that is pretty end stage stuff. What do we have here? We have a situation here, an 85-year-old female with known hypertension, chronic kidney disease, and diastolic heart failure. Today, she tells you she seems to be more confused. How do you reason through this? So, step one, is confusion cardiac, metabolic, or neurological? Well, what takes priority first? What always takes priority?
Cardiac.
Cardiac. That's exactly right, person at home. Cardiac always takes priority first. So in older adults, confusion is hypoperfusion until proven otherwise. Low cardiac output from heart failure reduces cerebral perfusion and can lead to systemic hypoxia and can trigger all these delirium symptoms. But don't anchor. It could also be obviously infection, stroke, etc. But because you have to have an order of operations, it would really help that you don't miss the obvious cardiac factors first, okay? Because that will kill her faster than any infection. So go after the cardiac symptoms first. How does diastolic heart failure with preserved ejection fraction set the stage? So high heart failure with preserved EF means stiff ventricle, impaired filling. These people need a higher preload, overly aggressive diuresis or dehydration leading to low stroke volumes and cerebral hypoperfusion. That would be bad. So don't over diurese someone that's hypoperfused. Hypertension worsens LV stiffness, chronic kidney disease impairs volume regulation. So those are the things. Now, typically, a nice elderly lady who's confused, she may also be confused and dehydrated at the same time, right? So this is a precarious situation. You don't want to drown her, but she may need fluid to get her to perfuse. And so you're in a state of, why is the dehydration causing the confusion? Because there's not enough perfusion for the brain. So you gently rehydrate this person. Step 3, what bedside markers are helpful? Well, vital signs, obviously, blood pressure, heart rate, O2 saturation. A good indication of perfusion is mentation, urine output, and skin temperature. Those are low tech. People take them for granted. Is there pee in the bag? Do you know what day it is? And how good is your skin? Good to go. That's a good indication. And then, of course, you can listen to the lungs for crackles. You can look for jugular venous pressures. And then you can do the labs, the electrolytes, the creatinine, the renal perfusion, et cetera. So the thing that demands escalation in this case, the thing that says, I need a specialty consult or I need you out of my office, hypotension, especially in someone that's hypertensive normally, low urine output, rising creatinine, severe dyspnea, pulmonary edema, new arrhythmia, especially AFib. These is why these people transfer to the hospital. So you want to know in primary care, if that's where you're working, what generates the need to go in. Persistent altered mental status, in you go. AFib, new, in you go, right? These are things worth sending them out for. If overload, so they're wet and warm, she may need gentle diuresis, but you have to watch for chronic kidney disease because then you'll tip her into a low outflow state and that's not helpful. If she's underfilled and she's cold and dry, she may be preload dependent, so small fluid boluses might restore her. If the airway is clear and she can talk, she can drink water. That's a way to do it too. That's, drinking is a way to get fluid. And if the confusion persists and the vitals are unstable, that is your transfer person. Okay, let's see here. Here's another case of a 67-year-old woman who comes in with fatigue, mild shortness of breath. She denies chest pain. What's the trap here? So not all dangerous cardiac conditions present with chest pain, especially in older adults, especially in women. Ischemia and heart failure often present atypically. What is she presenting with? Fatigue, dyspnea, weakness, confusion. This could be the anginal equivalent. This is why women get missed when it comes to heart disease and elderly. This is an atypical presentation of cardiovascular disease. So what could be going on? Well, coronary ischemia without chest pain, that's a silent MI. That's more common in diabetics, by the way, because of autonomic neuropathy. Heart failure, fatigue, and dyspnea can be early markers of elevated filling pressures. She may be anemic. She may have thyroid disease. She just may be deconditioned. It's not all cardiac, but you always start with the worst possible case scenario first and then work your way backwards. Okay, you want to always look for red flags, syncope or presyncope, dyspnea at rest or orthopnea, hypotension, tachyarrhythmia, new murmur, crackles on exam, JVP, ECG changes, chest x-ray, echo, cardiomegaly, fluid in the lungs, etc. Okay, depending on where you work determines what your availability will be. So now we're going to talk about kids. So there is a movie I put on here. If you have the option to watch it, I highly recommend it. It's called Something the Lord Made. And what this is about is this black lab technician who helps Dr. Alfred Blalock, a surgeon at Johns Hopkins at the time, discover the medical model for treating tetralogy of Fallot. Tetralogy of the Fallot is a congenital heart defect, but it's consistent of 4 different defects that can occur. They are ventral septal defect, overriding aorta, right ventricular outflow tract obstruction, manifesting through pulmonic stenosis, and right ventricular hypertrophy. So think about those 4 defects that are going on. What might you notice about this individual? Ventricular septal defect. What does that mean? Hole in the ventricle, right? So blood can go back and forth in the ventricle. Overriding aorta. The aorta is what? The outflow tract from the left ventricle. Overriding, right? Means it's going to be some increased resistance. Right ventricular outflow. Well, I told you, where does the blood go from the right ventricle? To the pulmonary artery, right? So if you have pulmonary artery stenosis, blood can't get out that way. So it's backing up. So you have higher pressure in the right ventricle, which is normally a low pressure system, than you do in the left ventricle because the left ventricle can't pump out. Right? So what happens is you have a high pressure right ventricle and a hole in the septum. You're getting a right to left shunt. That right to left shunt means deoxygenated blood is shunting to the left ventricle where you expect oxygenated blood to be, and then it's pumping deoxygenated blood back out to the body. So that is the pathology here. So they used to call these the blue babies. This is a right to left shunt, and it leads to systemic desaturation. So the clinical features are these clubbing, squatting behaviors in children because what they want to do is raise that left ventricular pressure. Well, the way you can raise it is if you squat down, it will build up the pressure, it'll clamp the venous system, and then you'll be able to be less blue. So you'll see this in the movie where they call them the blue babies, and they'll get very blue looking, and then they squat down and they pink up, and this gives them the clue as to how we should treat this. But it's a worthwhile movie. It's old, but it's well done. Yes. Yeah, anything that bends you in half. Yeah. Well, but these are kids. They're not, that's who we're doing. We're talking about kids here, right? So toddlers. Yeah. Toddlers? Yeah. Oh, toddlers squat all the time. They have the best body mechanics, by the way. If you want to learn to squat properly, watch a toddler do it. Yeah, no, they're running. I'm blue. They squat. Toddlers are very resilient. When we say cyanotic congenital heart disease, what this means is that deoxygenated blood is bypassing the lungs and enters the systemic circulation. The child appears blue because of the right to left shunt. And that is tetralogy of Fallot. There are others. There are acyanotic defects. These are shunting hemodynamics. So what we have here is a left-sided pressure higher than right-sided pressure. So when there's a defect, the blood flows left to right. That means oxygenated blood is recirculated to the lungs. And at first, the child isn't cyanotic, but the lungs are paying a price here. This can happen with atrial septal defect. That's a hole between the atria. The left atrium and the right atrium will shunt. The right heart dilation will occur because too much blood is now occurring in that right atrium. Another one, you can just have a straightforward ventral septal defect. That's a hole between the septum of the ventricle. The left ventricle is high pressure, oxygenated, because there's no outlet flow in the right ventricle. So you're getting oxygenated blood shunting back to the right ventricle. And that can lead to things like failure to thrive and a dilated right ventricle. There's also patent ductus arteriosus. This is a pulmonary artery shunt. This is the continuous machinery murmur. What they do with this is they give an NSAID, like indomethacin or Advil. And what happens is the prostaglandin closes it, essentially. The prostaglandin keeps it open if needed, but for ductal dependence. So this is the reason that in third trimester pregnancy, you don't want to give NSAIDs because you can cause a premature closure of the septum. We want that septum to close like within 24 hours of birth. So this is why, despite all the hoopla around Tylenol, it's the safest option we have in pregnancy because it's not going to prematurely close off the septum and cause a cardiac defect in the kid. The other problem, of course, is we know that high fever and the reason you take the Tylenol is also teratogenic and can cause problems. So there is nothing without trade-offs. However, if you're going to have to take something for fever in pregnancy because raising the temperature over 102 is teratogenic and problematic, that's when we have to get into having to use something like Tylenol, because if we use an NSAID, that's far worse. So we have limited options. Life is trade-offs. Okay, another one that you need to be aware of are these obstructive lesions. So coarctation of the aorta, that's an upper extremity hypertension, diminished femoral pulses. That's how that's diagnosed. Aortic stenosis and pulmonic stenosis, these are other defects. Pressure overloads in the heart leading to concentric hypertrophy. So anytime you have a buildup of pressure, the muscle behind it is going to get bigger because it has to handle more volume. So if these shunts are left uncorrected, the chronic left to right shunt, what happens is the flow damages the pulmonary vasculature. It's just too much to handle. Pulmonary vascular resistance will go up until it exceeds systemic resistance. And then at that tipping point, the shunt reverses direction because it's now too much outflow obstruction to pump against. And you then will develop a right to left shunt, become cyanotic, but now we have no more compensatory mechanisms and it's really bad. So this is a big condition to worry about. The most common is the ventral septal defect that causes the cyanosis. Okay. So where are we at here? Kawasaki's. We have to talk about this because it would be bad if you miss it. But the upshot is this is generally in children. It's an acute medium vessel vasculitis in children. It's the leading cause of acquired heart disease in developed countries. The danger here isn't just the acute illness, but the acute coronary aneurysm that can develop afterwards, that can thrombose, rupture, and cause the child to have a myocardial infarction. So the big red flags you need to pay attention here too are the crash and burn. So crash and burn is a mnemonic. If you have a child with a fever for 5 days plus 4 of 5 symptoms, and the 4 of 5 symptoms could be bilateral conjunctivitis, polymorphous rash, cervical adenopathy, mucosal changes, namely that strawberry tongue or cracked red lips, and extremity changes, swollen hands and feet, and peeling skin. So 4 of those 5, that's the red flag there. And the mnemonic crash and burn conjunctivitis, rash, adenopathy, strawberry tongue, fever, and the way it's treated is IVIG and high-dose aspirin. So this is the rare instance in which children will get an aspirin. The reason for the aspirin is we want the anti-inflammatory, anti-platelet effect. So that's why they're getting it. This is an immune-mediated response. That's why we're giving them IVIG infusions as well. So any child with a prolonged fever and mucocutaneous findings, prolonged 5 days, you need to think Kawasaki's and get this dealt with. The big condition is myocardial infarction in a child. Oh, you should also know that cardiac defects in children they don't come and say palpitations and chest pain. What they will have is unexplained fatigue, poor feeding, and syncope as their symptoms. So if a kid does not eat and play, that's a red flag because that's basically all they do is eat and play. So if your kid's not eating and playing, that warrants an investigation. Same in psychiatry, by the way. Big triggers in psychiatry. I just did the feeding eating disorder lecture last night. It's online if you're bored. But suffice it to say, those are major red flags. So let's talk about pediatric arrhythmias now. These aren't just adult problems. Children get them too. The way you recognize them is the most common pediatric arrhythmia is SVT, rapid narrow complex tachycardia, often due to accessory pathways. Infants will demonstrate poor feeding, irritability, pallor. Older children will have palpitations, but they not be able to tell you about it. So you have to look for those symptoms. AFib is quite rare outside the post-op congenital heart, baby heart complex. So they can have VTAC may arise from myocarditis, cardiomyopathy, or congenital heart repair, and it can present just with sudden collapse. And then the congenital long QT syndromes, you should be aware of those. There are some genetic mutations, they're on the screen there, but this is dealt with pediatric cardiology and genetic counseling. If there are triggers such as exercise, emotional distress, or various medications, that can prolong the QT interval. Now, we're not normally doing EKGs in children, so you have to have an index of suspicion to even bother doing the EKG. So that's why you need to pay attention to eating and growing and developmental problems. If they're stable SVT, the management is Valsalva and ice. Just chill them down, trigger the diver's reflex, put their face in cold water. That helps. Have them bear down, check a rectal temperature, things like that. You can break the SVT that way. If that's ineffective, then they go down the ACLS protocol of adenosine and the like. Long QT and VTAC, magnesium, same for adults as well. That's the treatment there. All right, let's take a look at back to the people that we really deal with. The 70-year-old woman with a history of hypertension, diabetes, prior myocardial infarction. She presents acutely with shortness of breath, orthopnea, and swelling. And what's the primary diagnosis you should be thinking about here? Is she compensated or uncompensated? What's her pressure? High, but not terribly high, but she's compensated, right? The way you confirm this is essentially, well, she's dyspneic orthopneic, but she's got enough blood pressure that you have time that you don't need to rush her off somewhere. The vital signs are tachycardic, hypertensive. Is she hypoxic here? What's her oxygen level? Do we have one? So this is essentially how you're going to decide. So the question is, how do you treat this one? Well, if she is hypoxic, this is someone you could consider BiPAP or CPAP. You don't have to quickly go intubate this person. IV loop diuretics to diurese her, vasodilators like nitroglycerin to reduce preload and afterload, especially if the hypertension continues. If she were cold and wet instead and congested and hypoperfused, that's the most unstable situation. So you avoid aggressive diuresis until they're in a controlled setting with that type of patient. And then if you're going to do outpatient monitoring in this CHF patient, it's daily weights, urine output, bring them back for renal and electrolyte function, echo. And the red flag is any sign and symptom of hypoperfusion, essentially, or refractory hypoxemia. Okay, so we're going to close this out shortly here. So the big cardiac red flags, syncope, especially with exertion and palpitations, think arrhythmias, aortic stenosis, hypertrophic cardiomyopathy, chest pain that's unrelieved by rest or nitroglycerin. You want to think acute coronary syndrome until proven otherwise. Dyspnea at rest or orthopnea or paroxysmal nocturnal dyspnea, that's decompensated heart failure until proven otherwise. Edema, rapid weight gain, those are signs of fluid overload. Confusion in a cardiac patient, elderly especially, always suspect hypoperfusion. Hypotension, shock, cold extremities, that's cold physiology, that's high risk. New murmur, muffled heart sounds, or pericardial rub, that's valvular catastrophe. This is your ICU patient, pericarditis, tamponade, etc. Pulmonary edema with frothy sputum or hypoxemia, 911 to the ER. That's a big deal for heart failure. Anyone that's pulseless, electrical activity or otherwise, that's outside your domain, 911 to the ER there. So the red flags can be subtle. Sometimes they will scream at you. And so if any of these come your way, you should have an idea about how to escalate them. So the thread that ties this all together, preload, afterload, vascular resistance, and contractility, you can use those scores and tests to help you stratify risk as to who to treat and how aggressively. Remember, the treatment should not cause harm. So when you do CHAS-VAC, you'll do also HAS-BLED because you want to make sure, yeah, we're preventing a stroke, but we don't want to induce a bleed. So those are all basically tools that you can use to help you stratify your patient to know how severe the situation is and how aggressive you're going to treat them. So don't memorize all the tools and rules. Just learn to observe patterns and ask yourself, are you stable? How do I know? How long did it take to get here? That's about how long I should take to resolve it. What are downstream effects? What are upstream effects of the problem that you are experiencing? That's all I have on cardiac. Are there any questions at home or here? Oh, 11 things in the chat. Oh, who wants to tell me the difference between an artery and a vein? Artery and vein? Veins have valves to prevent backflow. Well, not exactly, but yes. Arteries are thicker. Yes, but that's not the difference. Artery carries blood away from the heart. Veins carry blood to the heart. Not does it matter if oxygen or not, right? Because the pulmonary artery carries deoxygenated blood away from the heart. The pulmonary vein carries oxygenated blood to the left atrium. That's the difference. That is the difference. That's the only difference. All right. That's all I got here. And this.